Hello, my name is Marcos Volques and today I am going to talk about Dapagliflozin in patients with heart failure and reduced ejection fraction. Definition: in patients with type 2 diabetes, inhibitor of sodium glucose cotransporter 2 reduce the risk of a first hospitalization for heart failure, possible through glucose-independent mechanisms. More that are needed regarding the effect of sodium glucose cotransporter 2 inhibitor in patients with established heart failure and a reduced ejection fraction, regardless of the presence or absence of type 2 diabetes.
So the heart failure community is delighted to see the results of DAPA-HF. There was a signal that the SGLT2 inhibitors had an impact on the incidence of heart failure and the development of heart failure, but DAPA-HF said in patients with established heart failure, I can't say the whole long word, DAPA actually reduced hospitalizations for heart failure and overall outcomes are beneficial. This is in patients with and without diabetes and heart failure with reduced ejection fraction. This is great news. This means we have yet another drug. The clinical implications is that the heart failure clinician needs to figure out where to add that and when. The DAPA study population were well-treated patients. They may not have all been on ARNIs, but they were on good regimens of beta blockers, ACE or ARBs, and some on MRA. So this was a well-treated population. Does that mean we have to wait till people are on standard medical therapy? This is what we're going to have to figure out, and there'll be lots of discussion.
Applications in medicine. Large clinical trials involving patients with type 2 diabetes have shown that inhibitor of sodium glucose cotransporter 2 reduce the risk of hospitalization for heart failure.
The benefits of dapagliflozin were identical in patients with and without diabetes, and even more so among the patients without diabetes. The benefits of dapagliflozin were consistent right across the spectrum of glycated hemoglobin, so even patients with a completely normal hemoglobin A1C got as much benefit as other patients. And clearly that questions the idea that in heart failure this is just about lowering glucose. And in fact, the patients without diabetes randomized to dapagliflozin had no reduction in hemoglobin A1C either, again questioning the benefits in heart failure just being about reducing glucose. So the alternative possibilities are that these agents do have, at least in the short term, a diuretic effect. That might be beneficial, but it's unlikely to be the whole explanation. These drugs do protect the kidneys, do slow the progressive deterioration in renal function that we see in patients with heart failure. We've reported that with dapagliflozin, both in patients with and without diabetes. And then I think the third idea, at least, is that these drugs might have beneficial effects in the heart. Now, these are largely still in human beings hypotheses, but probably the two major ones are firstly that these drugs might improve myocardial energetics, make the heart more metabolically efficient, and in that way work better. One reason why that might be is because they increase production of ketones, and you can think of ketones in a very simplistic way as a super fuel for the heart that are more metabolically efficient. And then the other explanation, but again very hypothetical and experimental, is that SGLT2 inhibitors might interact with what's called the sodium hydrogen exchanger on heart muscle cells, cardiomyocytes, and by reducing intracellular sodium might, for example, reduce the risk of sudden death. But we don't have any firm human evidence for that. It's a speculative mechanism.
Pros and cons. Most patients in these trials did not have heart failure at baseline, so the benefit of treatment with an sodium glucose transporter 2 inhibitor largely reflected the prevention of incident heart failure. One of the positive effects of dapagliflozin in patients with heart failure is a reduction in the risk of hospitalization, as well as a decrease in emergency room visits for conditions derived from this condition.
Studies have shown that in patients with type 2 diabetes, inhibition of the sodium glucose cotransporter 2, or SGLT2, reduces the risk of hospitalization due to heart failure. The mechanism by which this occurs is not yet understood. It's been hypothesized that SGLT2 inhibition may prevent heart failure complications, even in the absence of diabetes. In this multicenter randomized placebo-controlled trial, 4,744 patients with New York Heart Association class 2 to 4 heart failure and an ejection fraction of 40% or less were randomized to receive either dapagliflozin or placebo in addition to standard heart failure therapy. Randomization was stratified by the co-diagnosis of type 2 diabetes. The primary outcome was a composite of a first episode of worsening heart failure or cardiovascular death. Over an 18.2-month median follow-up, the primary outcome occurred in 16.3% of the patients receiving dapagliflozin, as compared with 21.2% of those receiving placebo. The findings were similar in patients with or without diabetes. The rates of adverse events were not significantly different between the two study groups, with volume depletion and renal dysfunction being the most common. The authors concluded that in patients with heart failure and reduced ejection fraction, dapagliflozin reduced the risk of worsening heart failure or cardiovascular death, even in patients without diabetes. Full trial results are available at nejm.org.
Issue applied in Ecuador. Dapagliflozin reduced the combined risk of death from cardiovascular cause and hospitalization for heart failure in patients with type 2 diabetes mellitus with and without kidney disease.
Based on the DAPA-HF data, we are in the regulatory process to get a indication for the treatment of heart failure in both type 2 and non-type 2 diabetic patients. But beyond that, that's just the beginning. We also are studying Farxiga in CKD patients, as well as later on we have a study going on in HFpEF in heart failure also. So really what you've seen with the label update that we had last month, what you're seeing with the data that's being presented with DAPA-HF is just the start of the investment, the scientific investment that we've made with Farxiga. We're in the process, and some of the data that we're presenting here at AHA is looking at different patient characteristics, whether it be obesity or age, and also looking at the time in which you could see impact, a positive clinical impact in patients with heart failure. And all of these data will be part of what we take forward and discuss with the FDA around future labels.
Conclusion: the DAPA heart failure study showed that dapagliflozin significantly decreased cardiovascular morbidity and mortality, and particularly that related to heart failure in patients with and without diabetes and who were carriers of heart failure. The importance of the results of this study will probably impact the recommendation for the treatment and prevention of heart failure in the international guidelines.
So we designed the DAPA-HF trial to test the hypothesis that the glucose-lowering SGLT2 inhibitor dapagliflozin might be of benefit in patients with heart failure and reduced ejection fraction when added to conventional therapy. We designed the trial to see whether that was the case in patients with diabetes and in patients without diabetes. The latter constituted 55% of all of our patients. And we found that dapagliflozin reduced morbidity and mortality and improved symptoms overall and individually in patients with diabetes and also in HFrEF patients who did not have diabetes. In addition to that, dapagliflozin was very well tolerated compared to placebo, and in patients without diabetes, we saw no evidence of hypoglycemia. We saw no cases of diabetic ketoacidosis.